Hello everyone, my name is Maida Rudolph, and today I'm walking you through our new multicentric retrospective cohort study examining whether long-term preoperative beta blocker use is associated with postoperative ischemic stroke after non-cardiac surgery. We have known for years that beta blockers have been central in cardiovascular medicine. A prior large clinical trial showed an increased risk of stroke when beta blockers were initiated just before surgery. In this study, we ask a different question. Among patients already on long-term beta blockers, is there an increased risk of postoperative ischemic stroke? In this study, we analyzed more than 289,000 adults undergoing non-cardiac, non-ambulatory surgery across two major US academic hospitals between 2005 and 2021. Among those with long-term beta blockers, the incidence of stroke was 6.1% after 30 days and 15.4% after 365 days, compared with 1.6% and 3.3%. The key finding is that long-term beta blocker use was associated with a higher risk of stroke. Interestingly, patients with a low ASA physical status had nearly double the risk compared with those not on beta blockers. However, in patients with severe heart failure or a pre-existing history of stroke, there was no significant association between beta blocker use and stroke. What does this mean for clinical practice? Long-term beta blocker therapy might not always be harmful in the perioperative period. It depends on the patient's underlying cardiovascular profile. Beta blockers can help by blunting sympathetic surge, reducing inflammation and thrombin generation, preserving cerebral autoregulation, and stabilizing rhythm and diastolic filling. But they can also push patients toward hypotension, bradycardia, or limit vasodilation when the brain needs it most during surgical stress. In conclusion, long-term beta blockers were associated with an increase in the risk of stroke both within 30 days and up to 365 days after surgery. This association was not observed in patients with severe heart failure or pre-existing history of stroke, but was amplified in lower-risk patients. It highlights the need for individualized decisions, especially in lower-risk patients when the balance of benefit and harm may differ from what we have traditionally assumed. I hope you enjoyed learning about our study.